brief description of Mr. Sylvester Simando. Uh, he is, just a minute, he is a star in the world of clinical research and public health, and as a clinician and a research coordinator at Ifakara Health Institute, he is deeply involved in advancing biomedical research and clinical trials. He has professional affiliations which span from the Medical Council of Tanganyika to the medicine and hygiene. He's truly an advocate of innovation in health. So let us give him a warm welcome as he shares his insights with us. So you can just press that emoji of claps as we welcome him. Welcome, Mr. Sylvester.
Thank you so much. So it's good to meet you people here, working in different fields, students. Been working in malaria for almost 5 years now. I've come to understand how complex malaria is. It's a very complex problem, and it's not easy to solve. That's why we need integrated approaches, multi-sectorial integration, so that we can tackle this problem. And most of us are working in several dimensions of malaria, but sometimes we forget the political dimension or the political part or the political aspect of this issue. So will you please share my presentation? Or should I proceed sharing? Okay. So I will start by a brief background, which my colleague, Dr. Masele, have presented it very nice. Go on to the next slide, please. Yes, as it was presented earlier, the burden in 2022, we had almost 250 million cases of malaria in the globe. And that was an increase of about 5 million cases. And there were about 13 million cases in pregnancy, which is 40% of all pregnancies in 2022. Also, the malaria incidence was 58 cases. The incidence rate was that. And Africa accounted for 94% of all cases, as it was presented earlier. So you can see how Africa is getting a big and a huge burden of malaria. So we had about 620,000 malaria deaths in 2022. We can say every minute we lose someone of malaria. So the burden is big. So there's no change in percentage of malaria deaths in children under 5 of age, which is 80% of that 620,000, 6,000 deaths. So 80% are children under 5. And because of maybe weak systems, we don't collect as much data as it is required. This can be underestimates. Maybe we have more deaths than that. Next slide. So we have had efforts in eradicating malaria, and the governments, politicians, professionals have done their part somehow. So we need at least to be grateful of some things which have been done. In 2015, the World Health Assembly of United Nations sat and came up with three pillars or the strategic framework to eradicate malaria, which set the target to reduce malaria to at least 90% by 2030. And the pillars were first to ensure universal health, universal access to malaria prevention, diagnosis, and treatment. The other pillar was accelerating efforts toward elimination and attainment of malaria-free status, which is eradication now. And the third pillar was transforming malaria surveillance into a core intervention. In my presentation, uh, I will, I will, I will target more on the first pillar, the first element. And if you see at the bottom there, in order to support the element one, we need to harness innovation and expanding research. So we'll talk more about this. Next slide. So, in case management and prevention, as it was mentioned in the first pillar, universal access to malaria prevention, diagnosis, and treatment. Here, in diagnosis, we have made an achievement, of course. Most African countries now we are able to diagnose early malaria by using RDTs or microscopy. For example, in Tanzania, the gold standard in all primary health care facilities is RDT. And some countries in East Africa, like Rwanda, the gold standard is microscopy, even in the primary care facilities. Treatment, almost every country in Africa, we do prompt treatment within 24 hours of diagnosis with safe and effective anti-malaria. Currently, for example, in Tanzania, we use ACTs, antimethyl lumefantrines, and with the discussions that are ongoing, we are aiming to go to TACTs, which is triple artemisinin combination therapies, due to the threat of antimalarial drug resistance. But also, we have been doing drug efficacy, and we've been doing this regular monitoring of antimalarial drug efficacy to inform the national treatment policies and ensure early detection on and response to drug resistance. As you have all known that we're using ACTs now, but we didn't use these ACTs 20 years ago. We're having some other drugs of choice, but now, due to the surveillance, due to this monitoring, we are able to be informed of the resistance or other adverse events that made it possible to change our policies and our standard treatment guidelines. But also, we have had other malaria control tools, such as insecticide-treated nets. For example, in Tanzania, we have factories for manufacturing this, for producing these ITNs of best quality. We have insecticides. We have to some places of Tanzania, as the first speaker, Alois, said, we have stratified the National Malaria Control Program have stratified the country according to the level or the pattern of transmission. The high transmission areas, moderate transmission area, and the low transmission areas. So to the high transmission areas, we use indoor residual spraying as the malaria control tool. We do also have drug prevention. To some countries in Africa, they do provide seasonal malaria chemoprophylaxis, SMC, and these mostly the West African countries with the clear malaria seasons, which are intense but a short period of time, usually 3 to 4 months of intense transmission. So they usually provide these drugs just before the start of the seasons. But for us, East Africa and other countries, we don't have clear seasons. Of course, we have some peaks, malaria peaks during some rainy season and whatever, but we have malaria transmission throughout the year, so we don't need these SMCs. But also IPTs to pregnant women who provide these preventive therapies during their antenatal clinics. So with all the tools, um, we also have these tools to come, like vaccines, monoclonal antibodies, genetically modified mosquitoes. In the case of vaccines, I'll talk more about that, but also monoclonal antibodies are other interventions that scientists are trying to work on the research for them, but they seem to be somehow expensive than vaccines or the conventional control tools. But also genetic modified mosquitoes. At Ifakara, we have the um, we have this project called Transmission Zero. Of course, we have started producing these genetically modified mosquitoes. We're doing it slowly, involving the government. We have started now sensitizing the community about them. And soon or later, they'll start rolling these mosquitoes out just to as as one of the um, control tools. Next slide, please. So, as I said, I will talk more of the first pillar, ensuring universal access to malaria prevention, diagnosis, and treatment in the context of political will. So I said in supporting this element, it needs harnessing innovation and expanding research. So these are the tools that we are using. We do vector control, we do diagnostic testing and treatment, which we have invested a lot. But also now we have vaccines. Also, we do surveillance. My colleagues have talked about this surveillance. They have talked about treatment and vector control. So I'll go deep on the vaccines. Despite the malaria having more deaths annually than COVID-19 or other infectious diseases, as we saw, in just 1 year, more than 500,000 people died of malaria. We have one death every minute. That is a lot more than people died in COVID-19, Marburg, Ebola, or any, you can name any infectious disease. But the current interventions now that we are implementing, which have helped much, cost 5 billion US dollars annually in Africa. We don't see much investment in malaria. Next slide, please. So since this parasite were discovered, 114 years ago, 145 different malaria vaccines have entered clinical trials. But due to the complexity of the malaria parasite, up to today, I can say, the WHO has only approved and recommended only 2 vaccines. The RTSS, which was approved and recommended in 2020, and the R21 matrix M vaccine, which was approved and recommended in 2022. Luckily, Kenya, Tanzania have been part of the process of the research of these vaccines since phase 2 clinical trials and the phase 3 clinical trials. And during the RTSS vaccine trial, the phase 3 trial, Tanzania contributed a big number of participants compared to other countries. But also, the R21 matrix M vaccine is still, the trial is still ongoing, the phase 3 trial, and Tanzania is among the participating countries, contributing 600 participants. Also Kenya, we have 600 participants, and other countries in West Africa like Burkina Faso and Mali. So up to March 2025, malaria vaccines have been rolled out in childhood immunization program in 18 African countries. Funding for now in the conventional control tools is 5 billion a year, but only 780 million is needed for 200 million doses of malaria vaccines. The Gavi finding is available. The Gavi is the Global Alliance for Vaccine and Immunization. This is a I can say is an organization under WHO which help financing, organizing the funds and financing vaccine and immunization to the countries who need most. We only need 40 million we only need doses, 40 million doses for African infants every year. So you can see if we roll out these vaccines in our EPIs, we can cut the cost at large. It is estimated that the GDP of African countries could rise by additional 126 US billion dollars if the UN target to cut malaria by 90% by 2030 is met. So you can see our annual income, maybe our in Africa can rise up to 10%. Next slide. So childhood mortality was reduced by 50% between 2000 and 2015 because of the vaccines. We now have 11 different vaccines in our expanded program of immunization. We need to add this malaria vaccine to have the 12 vaccine. The infrastructures are there. Most of the countries, I can say they have improved the cold chain. We have electricity to most of the villages, and the prices for these vaccines are fine. The Gavi funding is available. So the challenge is mainly distribution and political will. You can see with all the conventional tools, we still have this big number of deaths. So we need to add another tool, which is vaccines, to supplement to these conventional tools that we have. No single tool can be able to eradicate malaria, but since 80% of the cases or deaths happens to children under 5, and this vaccine targets those children. These vaccines are 75% effective. That's why they were approved by WHO and recommended. You can see we are able to save more people, more children, than just spending a lot of money in this other things that are given priority by the politicians. Next slide, please. So we can analyze a little bit about Africans' political will. So there's a historical skepticism, as Dr. Franklin said before. There's a mistrust of these foreign vaccines. You can take an example during the COVID-19 pandemic, the way the prominent leaders were talking about the vaccines. For example, President Trump was very against the vaccines. We had President Magufuli, he was denying them. So maybe, sorry, yes. So maybe this is bringing some hesitation to governments or some the politicians, but also resource competition. There's not enough funding for the health budgets. You see, it's because, as also Dr. Franklin said, the leaders are able to set budgets for buying luxury cars, spending in traveling abroad and whatever, but in health, there's a limited funding. So that's a challenge also. Bureaucracy. So you can see most of the leaders or politicians like to invest where they can have something in return. In vaccines, it seems there's no much to take from there. So the bureaucracies, they are they can invest a lot of money in the project that they know it is not such helpful, but they can get something out of it than just approving these vaccines. So also public engagement gap. Dr. Franklin also said it well about the public health campaigns, the way you're doing, you have these NGOs with doing this advocacy, whatever. So we need to compare now to our regional peers. You know, Ghana and Nigeria was the first countries to approve the use of R21 vaccine before even the WHO pre-qualifications. But Cameroon, just a year after WHO approved and recommended RTSS, they introduced it in their EPI. And so, as Dr. Franklin explained, it was hard at the beginning, but I think they are doing good now. And malaria is reducing significantly has been reduced significantly in Cameroon. Next slide, please. So what are we recommending? High-level advocacy. Scientists, NGOs, politicians, and health officials should champion malaria vaccines, emphasizing their safety and efficacy to build trust and counter this hesitancy which is there. As at Ifakara, I've been conducting several meetings, giving feedback to the health authorities, the National Malaria Control Program. We have conducted several meetings with parliamentarians, explaining to them the results, the findings, and the benefit that we could get from rolling out these vaccines. But also, we are engaging other NGOs which are doing advocacy just to have the support. We're going to the medias. We are planning now to start the scientific podcast where anyone can join and hear what we really mean. But there has been poor support from the government and politicians, as I explained earlier. Also, we have presented the data to the National Vaccine Advisory Committee. We don't know what is hindering. We were there in the research, participating in research, developing these vaccines, but up to now, we have not rolled them out. Also, budget reallocation. The government now, this advocacy should go further to force the government to reallocate the budget, because currently African countries contribute only 30% in health sector, and they rely the 70% from foreign aids, which is a shame. We have the resources, we need to reinvest. You see, the USAID funding has been cut, and many things have been affected because we rely too much on the foreign aids than ourselves. But also to streamline this bureaucracy. Sometimes, if you ask why in Tanzania we don't have vaccines yet, you will not get the clear answer. Maybe we were saying maybe because we had RTSS and they were waiting for the data of R21. Now we have the data for R21. It has been approved. Other countries are rolling it out, but we're still there.
Mr. Sylvester, can you, because we're out of time and we have
Yes,
limitation of the
this is the
can
last.
you wind up so that we be able to?
Yes, yes. But also regional collaborations, as it has been explained earlier. Next slide, please, which is the last slide. I wanted to show you the vaccine distribution. These are the countries that have committed to deploy malaria vaccine in the period of 2 years, from 2024 to 2026 under Gavi. You can see countries like Chad, DRC, Mozambique, Sudan, Central African Republic, Nigeria, Uganda, and Ivory Coast have opted for R21 Matrix M. And Ghana, Kenya, Malawi, Benin, Burkina Faso, Burundi, Cameroon, also DRC, Liberia, Uganda, Niger, and Sierra Leone have opted for RTSS. Some countries have shown a really good political will to end malaria, and they are even going with both two vaccines. Yeah. So thank you so much for your time.
Thank you so much, Mr. Sister. That was a very informative and eye-opening session. So as we come to the end of the meeting, if you have any questions for Mr. Sylvester, I'm not sure if Dr. Messel came back, but if not, if you have any question for Mr. Sylvester, you can type it in the chat box or just raise your hand and I'll give you the permission to speak here.
Yeah, thanks a lot, Mr. Edwin. And thanks a lot to all participants. Because of our time, I don't think if we can take some Q&A questions, but I would like to take this chance to give appreciation to all supporters, all collaborators, and all partners who made this event very, very tangible to our community. Basically, from the very beginning, we had some stakeholders who have been collaborating with, raising awareness on malaria. And I would give this chance to our media coverage who facilitated this meeting, Moffat Tanzania, so that they should be able to tell us what do they offer, and basically we might have some ways on how we can work with them, collaborate with them, and basically reach the community we target to reach and reach the goal set by United Nations by 2030, being having a good health and well-being for the entire community and global in general. The president from Moffat, you are most welcome.
Thank you very much. Can you hear from me?
Yes, we can hear you.
Yes, my name is Moses Evaristo, president of Moffat, the mobile facilitation team sit long way. This is like a non-government organization that have been registered since 2023 with aiming of bringing out the talents, creativity, and innovations from the healthcare professionals in Tanzania. And so far, we use health digital artworks, where within it we have 3 figures. We have like designing, but almost we have hosting, and also we have the third compositions of marketing. So what we do is just we hold up different online sessions or webinars. So we have tried our level best to customize the tools that we use, including Google itself. It is not Google itself, but what we do is just we have buy the Google extension and we have modified so that it can catch up a lot of features that can be favorable to the meeting. So we hold up different meetings and we run them smoothly, and we make them to be live to the different social networks so that people they can follow on that. But the other issue that we are doing is like we are scheduling online sessions. So we schedule online sessions from the different perspectives or from different health professionals or that they are coming together to share. We have a different expertise that are coming to share their sessions, but almost to share their messages. But the other issue that we are doing is we hold and we host different institutions meeting or institutions orientations or launching activities that are relating to health professionals. So what we are doing the same. But almost the biggest issue that we have is what we call Mofata Academy, which now is being launched and it has a great opportunity for every healthcare professionals as you can use it as you use like Kiku. If you know Kiku, you buy clothes, you buy shoes, you buy whatever. But in Mofata Academy, you buy professional materials. So Mofata, we offer all of them because we know that the professional, they're investing much in the impact issues. So we want to make them return from themselves. So what can you now benefit from us when you engage with us? First of all, we make your event, we make your issues to be publicly reviewed by anyone. Like you can see, these sessions all will be out from YouTube channels, so everyone can take a follow-up even away from here. So the sessions will be living all the times if we want to hear and even to take a follow-up of that. So lastly, maybe it's not necessary so much to say, we have a working website that is www.mofate.com. This is an active website and it is an international website currently. And almost within it, you can find a lot of features and a lot of issues that you can engage with us. And then also we have social networks. We use all the social networks. We use just one name, Official Mofate. So if you find them, well, you can search and see artworks, how it works, artworks, how we have been designing the lot of issues that even hold and presents a lot of visibilities of professional activities. So I think these are the issues, but mostly final to say thank you, Yuda, for giving us a chance to collaborate with you. We know that we have responsibilities to collaborate with you guys because we are doing good issues to the community. So we are very proud ourselves to go with you in the different activities and also invite others to go with us because it is a part of our activities that we are doing for the benefit of the community and even the country at all. So thank you very much. I think this is like issues to say. Thank you today for Malaria Day. We have engaged a lot. We have learned a lot from you. You have a good guests and expertise that have been shared a good impact to us today. They have a good inputs. And I think for these inputs now we can say we have learned a lot. We have learned a lot. So just one request from you, Yuda, if you have another activities and you think that there are other activities that we can collaborate in case of preparing digitarian in terms of digitals, so you are welcome. We have a different systems, we can work together and to make everything alive. Thank you very much and I wish you all the best and have a good night.
Okay, thanks a lot. We shared the link for registration so that we should be able to upload and process the certificates for your participation. And the certificate will serve your commitment in learning, relearning, and unlearning, so that you should be able to empower the community with necessary knowledge, and the community should benefit from what you learn from different people, from different perspectives. And congratulations for Moffat for coming with this innovative idea, and hope this innovative idea should be emphasized, and through collaboration we should be able to reach many people as much as we can, basically in our country, outside the country, but also globally. And hope this is the beginning of learning, beginning of collaboration, but also beginning of networking. Let's network together, and build a healthier community together, and reach the target be set. And we should be able to celebrate this achievement as we African, as we are commemorating the African Vaccination Week. I would like to wish you good night, and have wonderful day, wonderful moment, and have wonderful celebration of different achievement you have, wonderful celebration of the work you are doing, even if it is very small, but to impact the community. Thanks a lot to our moderators. Thank you all participants. Thanks to all stakeholders who we collaborated with. And thanks for the participation from the very beginning to the end of commemoration. But this is not the end. We are starting afresh. Have good night. Enjoy the moment.
Thank you very much. Thank you very much, Yuda. Thank you. Nice night, all of you. We are very enjoyed ourselves. Today was very great. From Dar es Salaam, Bagala, Nyanza Primary School, we did a good job until this time. So thank you very much. We'll be sharing all the issues that happened today. I wish you all the best, and I'm very happy, and I'm very excited with you, and I'm very happy again to meet with you. Thank you very much. Have a good day. Have a good night. Have a good night.